You know, one of the most exciting things about this is the conversation about sequencing. So I'm an allogeneic bone marrow transplant doctor by training, and in practice I've spent my entire career trying to get T cells to do the right thing and not the wrong thing. And now we have these amazing drugs outside of the context of bone marrow transplant that look like they can do this. And we have these other drugs that may be able to enhance the process. Not to go too deep into the discussion, but 10 seconds on the immunology, you have two dynamics. You have the dynamic of the tumor, and the tumor, in the positive way, is expressing signals to tell the body, I am dangerous, come get me, get rid of me. And then you have the body, embodied in the immune system, recognizing that and going and doing it. But no different than any life form, tumors don't want to die, and they figure out ways around that. They hijack, if you will, the systems that suppress the immune system. And you know, a great example of this is pregnancy. If it wasn't for what the placenta did to tell the mom, yeah, it's obviously your baby, but half of the DNA in this baby belongs to someone else, and normally the immune system would go and destroy the baby, but the placenta, using things like PD-1 and PD-L1 and other things, actually tells, don't reject this child. But the moment the child's delivered, if you take a piece of tissue from that child and put it on the mom's skin, she'll reject it. The moment the child's delivered. So, no different. We are now understanding that complex dynamic, and we're modulating. We're making the tumor more recognizable to the immune system by using oncolytic viruses, by using molecules that cause the tumor to die quicker apoptotically, like BRAF inhibitors. And also we're using agents that stimulate the T cells beyond the checkpoint inhibitors. So you can imagine the combinations that we're going to come up with over the next 4 to 5 years that will take where we are today and bring it to a whole nother level. It is so promising and so exciting to be in the field right now, knowing that we're going to change the natural history of diseases like lung cancer, pancreatic cancer, colon cancer, where if you had a certain stage of disease, you were guaranteed to die. We're now going to change that. That's exciting. So today, the sequencing of drugs goes something like this. In melanoma, you test for a mutation called BRAF. If you have a BRAF mutation, you give a BRAF inhibitor combined with a MEK inhibitor, because the combination is better than the single agent BRAF inhibitor. That is not curative, but it will control the disease on an average for about a year. Now, once you've done that, you start to think about, how am I going to introduce my immuno-oncology drugs? And people, doctors and researchers, are now doing studies. Well, do I give the immuno-oncology drugs first? Do I give them with the BRAF and MEK inhibitor? Do I only give the BRAF inhibitor and hold off the MEK inhibitor? And there's reasons for that I won't get into. Or do I flip it around? We don't know the answer to that. That's why there's no real guideline. Doctors are sort of doing what they think is best. Some of it has to do with, I'll give the immuno-oncology drug first if the tumor's not growing that fast and it's not going after a vital organ in the next week or two. Whereas if you have someone that's in the position where their tumor's growing dramatically, or they have something that's pressing up against a vital organ, you don't have any time, those drugs work right away, like within a couple days they start to work, if not sooner. So you give those drugs first. If you don't have the mutation, then the question becomes, well, what do you do? So we now know from a prospective trial that the drug pembrolizumab is more effective than ipilimumab, at least in metastatic melanoma. Now, it's not yet FDA approved in first line where ipilimumab is, but I suspect because of those data, that will change. But that's not the end of the story. We also know that combining an anti-CTLA-4 drug with an anti-PD-1 drug is better than either drug alone, but there's a lot of immunologic related toxicity. So we will figure out how best to give these drugs and in the sequence we need to give them so that the patient gets the best outcome with the least amount of side effects. Going back to what we discussed before about the biomarker, there is now a growing belief that if you're a high expressor of PD-1, that maybe all you need is an anti-PD-1 and you don't need an anti-CTLA-4 drug, whereas if you're a low expressor, you need the anti-CTLA drug first or with the anti-PD-1 drug. But this is the very beginning of that discussion. None of what I said is FDA approved. None of what I've said is yet the standard of care. The standard of care is if you're going to give an immuno-oncology drug, you give ipilimumab first, and if ipilimumab doesn't work, then you can give an anti-PD-1 drug, unless, of course, you have a BRAF mutation. You can still give ipilimumab first, but if you're not going to give ipilimumab, or if you've given it, you then must give the BRAF inhibitor along with the MEK inhibitor, and then you can give an anti-PD-1 drug. But even as I say this, this is going to change pretty quickly.